what excites me about coming to a meeting like ESC. It's not just talking to really great people about things that they are passionate about, but it's also taking a look at some older trials that we have come to know and appreciate and finding out new details in analyses and sub-analyses. And so we've got two of those here and something a little unusual. I am with Dr. Marc Ditmarsch, who is the Global Development Lead for Rolanta at AstraZeneca. So the topic here we're talking about is ticagrelor. There's a couple of studies, Atlantic H24 analysis and Pegasus TIMI54 that has some data. Let's talk first about the effect of pre-hospital ticagrelor in STEMI patients the first 24 hours after primary PCI, and this is part of the Atlantic study.
Correct.
What are we learning?
Well, with this study, where instead of the top-line results, where we looked directly after PCI, we now looked at the total 24 hours results with the Atlantic trial. And then you really see that on the basis of the relatively little delta between the pre-hospitalization versus the in-hospitalization, you see the effect of ticagrelor kicking in within the first 24 hours, the difference between pre-treatment and in-hospital treatment. And then you actually see some trends emerging with regards to both of the co-primary endpoints.
Now, the original trial results was looking at, what was it, 30 days? 30 days.
That was for the 30 days was for the total of cardiovascular events. Okay. Now, the co-primary endpoints were just directly after PCI.
And so in this case, what we're seeing is that given just a little bit more time, the data is looking positive.
It's trending positive, because if you look at the co-primary endpoints, there's no significant difference between both of the co-primary endpoints, which
is encouraging.
Which is encouraging, but because the more thing which is really encouraging is actually that there's no negative aspect to it, because there's no increase in major bleeding within that time frame, as well as in the time frame for the original top-line results.
One of the pivotal trials for this was Pegasus TIMI54, and here we're looking at ischemic risk and efficacy of ticagrelor in relation to time from PTY12 inhibitor withdrawal. Remind us about Pegasus TIMI54, where the original study went, and then what you're looking at now.
Right. Well, with the original study, we studied the efficacy and the potential efficacy of ticagrelor in patients with post-MI, like more than 1 year out of their index event, and it showed a significant results both in the 60 as well as the 90 milligram arm of ticagrelor versus placebo. There was a relative risk reduction of about 15 to 16%, and that was quite significant with regards to the overall patient population. Now, with this specific sub-analysis, we actually show that if you discontinue your P2Y12 inhibition closely to be randomized within Pegasus, actually the risk of having another event in the future is high, but the effect of ticagrelor is actually substantial. It's substantially higher compared to patients who actually discontinued P2Y12 inhibitors much longer prior of randomization.
So what's the bottom line message out of this?
Basically, the bottom line message out of this is that there's a continued risk for a substantial subset of patients who have experienced an MI in the past. And it's difficult to identify those patients, but it is important that those patients are protected. So it actually indicates and suggests that continuation of therapy could be a very, very significant perspective for certain patients.
So what patients, how to describe these patients, I guess, might be a...
Well, that's the challenge. That's the challenge. That's going to be really the challenge. Well, and in that respect, we have done additional sub-analysis to identify potential additional patient populations that could actually provide a better insight. Now, we looked at gender, and we also looked at patients with specific, with renal function. And both of these subsets actually perform just as good as the overall patient population. So we haven't identified a specific patient population that benefits more than the other. So it's really up to a benefit-risk assessment of the individual physician to prescribe the appropriate patient population for ticagrelor in the long term.
This is just fun. It's a great paper. Effects of interactive patient support with a smartphone app on drug adherence and lifestyle changes in myocardial infarction patients. Trying to get drug adherence out of patients is difficult, no matter whether you're a physician, a physician's assistant, a nurse practitioner. They all have about the same, and I might say, dismal record. And it's obviously often not the doctor's fault. What can we do? And in this case, it's a smartphone app.
Yeah, I mean, you're absolutely right. Adherence is a big thing, and it's difficult to tackle. It's multifactorial, and I think it's appropriate to look at all types of potential interventions that could actually facilitate the adherence of patients in the long term. And this mobile phone app, which is very easy to use, really points us into one of the right directions to tackle this in the long run. And it also highlights that one of the results was clearly that patients were very satisfied by using this smartphone app. So both it's practical and patients really like and enjoy it to use it.
So what does it do?
What it does is actually it provides some text messages and reminders, both with regards to making sure that you take your medication, but also with regards to some implementations of lifestyle changes that could facilitate their benefit and their health.
So some patients, some older patients particularly, may not be that familiar with apps. There are hundreds of thousands of them out these days. But in this case, you've taken a look at a group of people and they like it. They can work with it and they can understand it, and that's not a problem. That's not a leap for them.
No. It should be fairly simple. The technology is not rocket science. Neither the suggestions that we provide them with, and it's actually very simple leads that you give them over the course of the rehabilitation. And it's for patients, it's very simple to use, and it provides them some insight with regards to a better way to rehabilitate and provide a better understanding of the future risks, as well as some facilitation with regards to managing their future risk.
I know years ago, one of my favorite papers was they were actually had a group of people. They were trying to figure out how to improve adherence. They were trying a variety of things. The technology just wasn't matching up with the audience. So they quit. They told everybody, fine, thank you very much. All the people got their cell phones out. Wait a minute, cell phones. And that was it. They're all looking, why were we trying all these other complicated things, and that they felt comfortable with?
Now there's a couple, there's intriguing, because there's a couple of interesting, for instance, features and knowledge that I wasn't aware of. But for instance, people respond much better to SMS messages versus emails, because you got a direct hit on your telephone. You usually see it blinking in front of your face. So these type of elements come into play as well. That's what I like about the beauty about technology.
Because you open your email and there's like 50 things facing you. You go, oh my God, what am I going to do now?
Exactly.
Well, you're right, with a text, a message like that, it's more direct in your face.
Exactly.
I love that. We have a variety of things from the ESC meeting that we are talking about online, in video, and in print. Please check them all out. For CardioSource World News, I'm Executive Editor Rick McGuire.